This is Talking Ears. My name is Juan Vasquez.
And my name is Frank Wardinger.
Frank, who do we have next on our NHCA series update in music audiology workshop?
Yep, our next guest is Brian Fligor. And we're going to be hearing his talk from the workshop on tinnitus evaluation and management. Now, quick thing about Brian. Brian is the person in music audiology that I've known the longest. He has the distinction of being the only person in hearing loss prevention that I'm aware of whose work has been spoofed on Late Night with David Letterman. He's researched and written extensively on sound quality with hearing protection devices, both with music listeners and with musicians. And he was the one who brought me into the fold with the National Hearing Conservation Association in the first place. And he's a dear friend. I spent my fourth year, which is the last year of clinical training for your AUD or your audiology degree, up at the Boston Children's Hospital. At the time, he was the director of the audiology program there. And I sought him out because he ran the Musicians Hearing Program. So I was really happy to be there because he allowed me to work with all of his music patients. He also brought me along to venues, concerts, festivals to see the musicians that we were working with. And as a side effect, I also sort of fell in love with pediatrics, and that was a field that I stayed active in for about 12 years after that. I was overjoyed at this conference to catch up with Brian. I've been meaning to have him on Talking Ears as a individual guest for a long time, so it's great to hear him talk about this topic.
It's always wonderful to hear from Dr. Fligor. Every time he speaks, I feel like I learned something new, and it just adds to a lot more insight, particularly with this topic of tinnitus management when it comes to musicians.
You know, the way that he talks about tinnitus, both from its scientific background and its clinical implications, is really eye-opening. So I'm overjoyed to bring this conversation to all of you listening. You can read more about Dr. Fligor's background and bio in the episode description, so I don't want to spend any more time up front. Take it away, Brian.
Back in the day, I learned from Dr. Santucci about how to go to venues and how to work with musicians and how to get them to respect their ears. Not just go in just to take an ear mold impression, ooh and ah over how cool it is to meet your, rock god that you grew up listening to, but actually be their doctor and take care of them because their ears are as important as everyone else's ears. So that's kind of how I grew up here at NHCA and with Sensophonics folks and with the rest of you. Life has evolved over time, and I've come to appreciate once things go wrong, and they do, despite all of our best efforts, we don't just, kind of do one of these and say, sorry, too bad your ears are now making this sensation that you can't do anything about, and there's nothing you can do for it. I decided that wasn't good enough for me. Over the last, I'd say, 5 years or so, frankly, since the pandemic, it's become my driving force now. About 90% of my patients are patients with chronic bothersome tinnitus. Many of them musicians, but not all. So this talk is geared toward working with all individuals who have tinnitus with a little sprinkling, little dusting, if you will, of the musical side of the world that we live in. How many of you in this room are willing to admit that you have tinnitus? Right. I would actually argue any of you who did not raise your hand, I'm not calling you out, but I will say you also do have tinnitus. Yours is what's considered subaudible tinnitus, which is a bit of an oxymoron, but tinnitus is a byproduct of how the ear works. In some models of it, it is circuit noise. It is how the ear has a spontaneous firing rate. As Dr. Leprell can explain in markedly better detail than I could, all ears, in fact, all neurons through our body fire, like just have this spontaneous firing. If they're not activated, if they don't fire every once in a while, they die. They actually don't get neurotransmitter, neurotrophic growth factors, these chemicals that our body feeds them to keep those cells alive. So they have to. And our ears are the same as all the other neurons in our body. They activate. They have to. Now, if there's some kind of process that's going on that causes that resting firing rate to be different, to be faster than what it used to be, if that resting firing rate is fast enough that it now is activating areas of our auditory cortex, we say, I hear that. There's a sensation there. Now, when it's a sensation that is not being caused by some external thing out in the world, but it's internal, and then no matter where we go or what we do, or if we plug our ears, we're still observing the sensation. Some people, many of us, don't like that at all. And we feel this loss of sense of control over what our ears are delivering to our brain. And it's not the sensation, but it's our loss of control over that sensation that is what actually causes this to be chronic and bothersome. We're here because we're trying to prevent or manage sound-induced auditory disorders, sound-induced auditory injuries. The number of musicians who call up an office and say, hey, my ears are ringing. Can you do something about that? Or can you help me? Or can I get some earplugs? Versus the number of musicians who call the office and say, I think I have a little decreased hearing sensitivity at 4,000 and 6,000 hertz. Can you come and help me out with that? Tinnitus is what drives them. Thinking about this, where I've set the stage that tinnitus being this chronic, bothersome thing, it's not the sensation itself, it's the reaction to it. This is some of the underlying concepts that Pavel Jastrzebow, who's a pioneer in the world of tinnitus therapies, this is kind of the concept that we want to grasp and then use to teach those individuals that we're working with, we're trying to help them. So this is kind of this mental construct that I have, that our experience of tinnitus, think of that as this serving tray, a charcuterie board, if you will, that is full of tinnitus. And the larger this board, the more tinnitus it can hold, okay? That board is held up by 3 legs. Those 3 legs holding it up are different parts of our brain. If one part of the brain isn't holding it up there, it's going to spill over and you're going to lose all your tinnitus, which kind of is what we want, okay? So the tinnitus is being held up by our auditory cortex, the part of our brain where we hear stuff, both the stuff that's causing our basilar membrane to jump up and down, okay, and send nerve impulses up to our brain and perceive it as an external sound, as well as that internal circuit noise that is our tinnitus. So our auditory cortex, this is where we hear it. If we don't like that, and we realize, oh my gosh, I can't turn it off, and it's there, and nothing that I do changes it. I can't take lipoflavonoid and make it just go away. That activates areas of our limbic system. The limbic system is also referred to as our lizard brain. It's this very instinctual part of our brain. It's the part that where we feel anxiety. It's where we feel anger. It's where we feel lust. It's primal. We don't have conscious control over this part of our brain. It just does. It's there on purpose to keep us alive. The hominids running around sub-Saharan Africa, hearing a twig snap, would startle to that, and they'd scamper up a tree. Now, those hominids that reacted strongly that way in an anxious behavior were the ones who survived and procreated. Okay, those that were curious and like, oh, what's that? I'm going to go check it out. And the leopard ate their face, did not have more, you're welcome, did not have more offspring. And so therefore, we are the product of anxious hominids. Therefore, we have condensed down through time to be very anxious little monkeys. Okay, and especially to things like smell and sound. Okay, so our sense of hearing and our sense of smell are 2 senses that they go right into our limbic system. They activate our amygdala. If you smell something that you don't like how it smells, immediate aversion and nothing you can do will cause you to then re-engage with it. It's to keep us from eating things that we shouldn't eat. It also causes us to not be able to date somebody if we don't like how they smell. Can't do it. It is also what causes us in the middle of the night when you hear that little creak in the house. What was that? And you slap your partner and it's like, go check that out. To which you're like, so you want me to die? Okay. I see how this goes. Okay. So if we hear something that is bothersome, it's not bothersome unless our limbic system decides that it is. And if that limbic system is activated so much that it identifies this sensation as a threat, okay, put quotes around that word, threat, that part of the brain tells the attention center of our brain, the thalamus, it tells it, that thing matters. That's a priority. That's a threat. We need to figure out what's going on with that. And so the thalamus gets activated. When the thalamus gets activated, this is like a spotlight at a school play. Okay, the person who's like shining on whoever's giving their lines. They're not shining it on the stagehand who's all dressed in black moving the set around. They're shining it on the lead who's giving lines. That is our thalamus. That's what it does. We have some conscious control over our thalamus, but it also behaves reflexively. One analogy that I give with the activation of the thalamus is you're driving down the road and you're in a 3-lane highway and you've got a semi-truck in front of you, you've got yourself, you've got a car to one side. You're listening to the music, you're probably having a conversation, and then all of a sudden you see the brake lights come on from the truck and you see it coming at you. You don't know that the radio is still on. You immediately stop talking and you hit your brakes, okay? Same thing if the guy next to you cuts in immediately and leaves very little room in between. Your awareness of these other things stops. That's because your thalamus is engaged on something that is in fact a threat. It's on purpose, it's important. But then once the threat subsides, then your thalamus shifts gears and goes on to whatever other thing it wants to do. Unless we consciously decide what I'm going to distract myself with or pay attention to, the thalamus will just go and wander on its thing. In this case, where somebody has chronic bothersome tinnitus, their thalamus is reflexively going back to the tinnitus all the time and can't not get back on the tinnitus unless they're actively distracting themselves. You do that 24 hours a day and you're exhausted. Well, when the thalamus is engaged in this thing and reflexively can't help but pay attention to it, it is communicating back over to the auditory cortex saying, hey, that sensation that is going on right there, the limbic system really doesn't like that, okay? And it's told me pay attention. So cortex, make sure I'm able to pay attention to it. So what happens is, and this is in all of our sensory cortices, we have a balance between our excitatory and inhibitory neurons. Inhibitory neurons are exquisitely important things. These are networks of neurons communicating. Their job is to find excitatory neurons. And when the inhibitory neuron turns on, its action is to turn off an excitatory neuron. This is how we navigate a very, very, very cacophonous, bright, scratchy world. We can tolerate the feeling of the clothes on our skin. We can tolerate really, really bright light. We can tolerate obnoxious people, sort of, because we have inhibitory neurons that are helping to suppress our sensations. One of the models of frank autism, but that is the term, frank autism. One of the sensations of frank autism, or one of the concepts of it, is that we have we have a downregulation of general inhibitory neural networks. So children who have frank autism sound as much too loud. They're using noise-canceling headphones, earmuffs in general, regular situations that other people don't find to be bad. The sensation of clothes or the texture of food is off-putting. So much of that is because they have a downregulation of those inhibitory pathways. We all have important inhibitory pathways. Our nose is within our peripheral vision, but we don't see our nose. That is because there is a neural network in our occipital cortex very specifically identifying the light that hits our retina and sends that signal back to our to our occipital cortex, visual cortex, and says, hey, there's your nose. Don't need to know that. I don't need to know about that. But we have an inhibitory network specifically designed to make our nose not observed, despite the fact that the eye is delivering that information to the brain every time our eyes are open. So these inhibitory neurons are awesome. They're really important. We need them. But when the thalamus sends a signal to the auditory cortex saying that thing's important, make sure I never lose my ability to attend to it, you get this imbalance where the inhibitory neurons, the minuses here, the inhibitory neurons are downregulated. And so the excitatory neurons kind of get going and they're more out of control. And that causes the sensation of tinnitus to be louder, which causes us to react more strongly to it, which causes us to pay more attention to it, which causes further downregulation of the inhibitory neurons, which causes it to sound louder. And you see the cycle. Good news is we've got 3 tiers on which our charcuterie board of tinnitus is sitting, and any one of those we can tackle, we can attack. This is not a small problem. American Tinnitus Association estimates somewhere around 50 million people in the United States have tinnitus. About 6%, so about 20 million, they find it bothersome. So what's the difference between the 50 million? Well, so there's 50 million people identifying as having tinnitus. 20 million find it bothersome. So that means 30 million have tinnitus, but they don't find it bothersome. That 30 million who don't find it bothersome, it did not activate their amygdala in their limbic system. That's the only difference. There's been numerous studies looking at what are the qualities of tinnitus that causes it to be bothersome. How loud is it? What is the pitch? What's the quality? Is it both ears? Is it one ear? What was the cause? It's not the loudness of the perceived tinnitus. It's not the pitch of the perceived tinnitus. Loudness matching and pitch matching for people with bothersome tinnitus and non-bothersome tinnitus, those populations overlap. Time and time and time again, when this is studied, it is, whether it's pulsatile, whether it is temporary, et cetera, it's whether or not it activates your limbic system. That is the difference. About 2 million people, 0.6%, are debilitated by their tinnitus. And by debilitated by their tinnitus, we're talking about individuals like the founding CEO of Texas Roadhouse, who he had a lot of stuff going on. It wasn't just his tinnitus, but he had long COVID. Tinnitus was secondary, was a consequence of his long COVID, and he committed suicide. Just the other day, I think it was February 3rd, Texas Roadhouse partnered with ATA, American Tinnitus Association, and all of the proceeds from that day, they donated to the American Tinnitus Association in his memory. You all know what tinnitus sounds like, I'm sure. I'm not going to play it, but just bear in mind that it's, again, it's not the perception of the tinnitus. It's keeping me from being able to fall asleep or stay asleep. It's the fact that I can't get away from it. People have described having chronic bothersome tinnitus as causing them to feel claustrophobic. It's an interesting phrase, but I've heard it time and again. It is significantly associated with anxiety and depression. Is it causing their anxiety and depression, or did their anxiety and depression cause their tinnitus? Correlation is not causation. When I work with audiologists now, neurologists, psychiatrists, and I got a whole team of people that I refer out to, and it's really kind of fun to work like with a network of good providers. I cannot stress enough how important it is to don't bother doing a hearing test, don't bother doing tympanometry or acoustic reflexes, talk to the individual and learn about them. They're going to talk for hours and hours and hours if you allow them. And so that's where it's important to be not just effective in this conversation, but also being very efficient in it and to gently help to steer that. But it's just absolutely imperative that when we have this conversation with folks, that we go walk into it with a framework of what it is that we are actually trying to do. What are we trying to capture here? Okay. I know you want to perseverate on your tinnitus because your tinnitus is perseverating on you. And it's almost as a person is talking and talking, they start repeating themselves, you can almost hear what's happening in their head as they're observing their tinnitus and not able to escape from it. And it's almost like it's not. They are getting significant emotional reward by telling their story. And because they're getting reward, they're doing it again and again and again. Okay. So it's important for us to identify that I want to hear how this started, hear what happened, and I want to know about this past week. How's this past week been? Don't tell me about 2 years ago. If it started 2 years ago, tell me about that. If there's a specific event that occurred that caused this to be the case. I put my in-ear monitors in. someone turned on an amp that was in line and they had it all the way up. And I had essentially like an open circuit white noise blast my ears. I couldn't get them out of there fast enough and my ears never stopped ringing. You can imagine that in that case, and that's actually the story of one of my patients, you can imagine in that case, that person experienced trauma. That was traumatic. Not just acoustic trauma where probably lost a good number of hair cells, okay? But also emotionally traumatic in that this most important thing to me as a musician is that these things work really, really well. And they still work well because I can hear everything and I know all the nuances, but I also have this essentially like a line running right on through everything. Frank gave a talk a number of years ago where he had a visual analogy of tinnitus where, it's a photographer who can look at a photo and can see whether or not it's really nice and detailed or if it's got some fuzziness to it, if the color palette is really, really vibrant or if it's dulled, and being able to tell the difference between, something that's a really nice photograph and one that's just kind of like, nah, not so good. And it's really interesting because I didn't even see this. I'm like, oh, okay. By comparison, one is a very vibrant photo with good detail. The other one was a little washed out. But then the visual analogy of tinnitus is you take that same photograph and now you just put a line through it. And that line's there in everything. It doesn't keep you from being able to see it all, but it's an additional noise. In this case, it's a visual noise, but in our case, it's an auditory one. When we do the workup, I do say, hey, don't bother doing the hearing test. Well, no, I really do mean do a hearing test. Like, let's really get an understanding of this. Primarily because how do we know that this person does not have otosclerosis? How do we know that this person does not have Meniere's disease? How do we know that this person does not have an acoustic neuroma? We need to identify what is it. That said, the phrase in medical school is when you hear hoofbeats, think horses, not zebras. I mean, I guess unless you're in sub-Saharan Africa, and then you might think zebras. But for the most part, at least in the United States, there's not too many zebras and there's a lot more horses. So if you hear hoofbeats, think horses, not zebras. So yes, we do. We want to identify and evaluate what's your hearing look like. Bearing in mind, though, that the testing itself tells us about that system, but it doesn't tell us what their experience with their tinnitus is. Okay? So thinking about that, back when I was trained, and I was trained by Billy Martin at Oregon Health Sciences University, by a couple other really smart folks out there. So I had some phenomenal people. We did a lot of stuff with pitch matching. We did a lot of stuff with loudness matching. And it turns out that if a person's insurance company actually pays for anything, if they do pay for tinnitus evaluation, the CPT code describes pitch matching and loudness matching. You could do that. It's of academic interest. And if the person really wants to know and understand what the deal is with their tinnitus and how important it is, or like certain aspects of it, you can do these psychoacoustic tests. Okay, I'm not going to tell you exactly how to do it, but that's for another talk. But I would suggest that you think very critically about whether or not you spend your time doing this, while at the same time, if you do it, you're asking an individual with chronic bothersome tinnitus to focus more on their tinnitus, like very intensely in a soundproof room. I can't think of anything more exquisitely uncomfortable than that. Many times people will come in knowing exactly their tinnitus pitch. And in fact, they will line up all of their tinnitus pitches and they will describe it all. Frank, actually, again, he gave a wonderful bit of work of his own tinnitus where he was able to do relative loudness of different components of his tinnitus. God love you, man. I would never do that. I don't want to know my tinnitus. The one piece that yes, we are frankly crazy. The one piece that I would suggest might be of importance and might be helpful is doing minimum masking level measures. So what is the lowest level of a broadband noise necessary to cause a person to not hear their tinnitus? Okay, to shift the audibility of their tinnitus. What is that minimum level required? So you can use broadband noise, you can use speech-shaped noise, white noise, which personally I find all of those sounds to be highly annoying, more bothersome than the tinnitus itself. But it may help to describe that while your tinnitus sounds very loud to you, it actually only required about 22 decibels of pink noise to mask it. And so being able to provide that and say, you know what 22 decibels is? That's below the level of a whisper. No. Yeah. Look, we did it again and again and again, and we got the same number. That's really impressive. That means that your tinnitus really doesn't have very much power. You can just do this one thing and just cause it not to be there. Whoa. Sense of control. I'm skeptical about doing psychoacoustics, psychophysical measures of their tinnitus. Questionnaires, though, that's really where it's at. Validated questionnaires, which we're going to talk a little bit about them, that gets at their reaction to the tinnitus, not just their perception of it. And as I described right from the very beginning, it's not your perception of your tinnitus, but is your reaction to it that is in fact what the problem is here. There is a device called the tinnometer. If you really do want to do loudness and pitch matching, it's a really nice device. I think Medrex licenses it from the people who developed it, the software in Europe. I checked it out. I don't have it myself, but if I were to do this routinely, I would do that. Bertrand Languth and de Ritter, these are a couple of the most brilliant tinnitus researchers in the world. They're based in Dublin, I believe. Just quoting here, the psychoacoustic assessment of tinnitus, such as loudness matching, hasn't shown sufficient reliability and validity for the use as an outcome measurement. What they mean is, if you're treating their tinnitus or if you're helping them to manage their tinnitus, the loudness of their tinnitus may not change, or it may change over time. In fact, it may get louder, but they're less bothered by it. And so as their tinnitus gets quieter, they may or may not find it to be better, which is mind-blowing to me. Everyone shows up and they're like, can you just make it quieter? Can you just make it quieter? Can you just make it quieter? Cool, let's work on that. But one of the things I say in my initial tinnitus evaluations as we look at how do we help you to live better is consider the possibility that your tinnitus, the pitch of it, how often you hear it, it may not change. It may stay exactly as it is right now, but if we're successful, you're not going to care. That makes absolutely no sense. I'm like, I know it doesn't make any sense, but let's just put that in the back of our minds. One of my patients who had a phenomenal outcome with her tinnitus therapy program, a woman named Wendy, who would drive down from Maine to my office outside of Boston in Beverly, Massachusetts. She had said, she was crying when she first met me. She had been fitted with hearing aids by another audiologist, didn't like him. They were causing her tinnitus to actually get louder, because this can happen. And when she returned the hearing aids, the audiologist, I don't know if their intention was good or not good, basically made her feel awful for returning the hearing aids and said, if you don't use these, then your tinnitus is just going to get worse and worse and worse. She's telling me the story and she's bawling. And so on the tails of that, I say, so whether your tinnitus gets quieter or not, I want us to just consider that that may not be a goal, but our goal is for you to not care if it's this loud or not this loud. She's like, I don't believe you, but okay, we'll figure that out. After about 14 weeks, I'm doing a telehealth with her. This is how we wrapped up, because she, the distances was a thing. She said, you were right. I absolutely didn't believe you, but my tinnitus is no different. It's just as loud as it ever was, but I don't care. Her questionnaire score went from about a 70 down to a 12. And you'll see what I mean by that. Like, why does that matter? Okay, so I know I'm probably running out of time, and we'll just see how we do. Scientifically validated questionnaires. We use these all the time in medicine. We use them all the time in lots of different things. Addiction medicine, pain management, and tinnitus management, just to name a few. So one example of a validated questionnaire is this thing called the Wong-Baker Faces Pain Scale. If you've ever had a procedure, like a surgical procedure, and you're in the post-anesthesia care unit, the nurse, the first thing they're going to ask as you're waking up is, on a scale of 0 to 10, how's your pain? This was developed by a child life specialist and a pediatrician because they couldn't they needed to come up with a way to evaluate the pain of children that they were taking care of. And this scale was developed back in 1983. It's continued to be used. It's still there. It's a mainstay. We can use this in people who have intellectual disability. We can use this in very young children. We can use it in people who are non-native English speakers, or whatever language doesn't have to be the one that care team is able to understand. This is very robust. Turns out a change of about 1, like going from a 6 to a 5, is in fact what's called minimally clinically important difference. It depends in part on status of the individual, their age, a couple other things. The range of what's considered a minimally clinically important difference varies a little bit, but it's pretty well understood. If my pain goes from a 6 to a 4, that was effective. If my pain goes from a 6 to a 0, that actually may be too effective. We actually don't want someone post-surgery to feel absolutely nothing. We actually want to know, hey, if I move this way, I'm tearing my stitches. So in the world of tinnitus management, there's been a lot of these developed, and there's pros and cons to all of them. I'm just going to point out, I was trained on using the tinnitus reaction questionnaire, which is pretty good. There's some downsides to it. The ones that I currently use in clinic, I use both the tinnitus handicap inventory and the tinnitus functional index. Both are really good. The tinnitus functional index is the most recent one that was developed by basically the authors of all these others and condensed it down into some really, really great stuff. It covers a lot of different aspects of how people experience their tinnitus. The tinnitus handicap inventory has been published more. It's been used as an outcome measure more in some of the tinnitus management approaches. So that's one reason why I still use it. The THI, like the TFI, 25-item questionnaire, the answers to the THI is no, sometimes, and yes. So there's a statement, and the patient's response is that answer, that gut reaction of, my tinnitus causes me difficulty to fall asleep or stay asleep. No, yes, or sometimes. Okay. A no corresponds to a 0, a sometimes corresponds to a 2, and a yes corresponds to a 4. You tally it all up across all 25 questions, and you get a score of 0 to 100. And a minimally clinically important difference is a change of 7. Okay, so if their score drops by 7, that means their tinnitus is better now. If their score gets worse by 7, that means it got worse. And there's ranges: slight, mild, moderate, severe, and catastrophic, that describe the severity of the individual's tinnitus. So how bad is a person's tinnitus? We do have categories for that. The TFI, very similar, but instead of a yes, sometimes a no, we have a scale of 0 to 10, kind of like that Wong-Baker-Faces pain scale, 0 to 10. There's 3 or 4 questions that represent 8 different subscales of tinnitus interference, if you will. Those subscales are the intrusiveness of the tinnitus, how loud it is, how often they hear it, and how annoying it is, but also sense of control, how easy it is to ignore it, how easy it is to shift their attention away from it. The cognitive interference, causing you difficulty to be able to maintain focus on something. Sleep, auditory, relaxation, quality of life, and emotional. These are independent. They're overlapping, but they have some independence among them. I'm not a big fan of how Jim Henry described the interpretation of the score from not a problem to a very big problem. It doesn't sound as cool and interesting as severe or catastrophic, but there's similar ranges. And in fact, there's a lot of overlap between the two. Now, if you're not familiar with how to administer those questionnaires, you really could use a visual analog scale. But the question is not, how loud is your tinnitus? It's on a scale of 0 to 10, with 0 being not a problem at all and 10 being the worst problem, how big a problem is your tinnitus? So understanding what is a minimally clinically important difference, it matters how the question is being asked. It matters, of course, which questionnaire you're using. In the Wong-Baker-Faces pain scale, turns out that, in a awake behaving adult who's pretty well oriented, a change of 0.9 is considered just enough to say my pain was better or my pain is worse. Could go so far as like a 2.7 if it's a younger child who doesn't have good language. The studies have indicated that the range may be as large as 2.7. But just to understand that there is a certain sensitivity, and we do have a good understanding of what makes it better, what makes it worse, and how to manage that. What I will say is we've got a lot of different strategies for how to help, okay? We can use sound therapy. Within sound therapy, we've got tinnitus retraining therapy. That's another approach that if you are certified in how to do that is really quite effective. Cannot downplay the whole point around mental health counseling and the use of medications if that's important. Something new-ish, but it is out, is something called bimodal neuromodulation. There is a device out there that is FDA cleared. My clinic happens to be one of the first 14 in the United States that started using it. I've fitted this particular device on a little over 300 people. I'll show you a little bit of data in just a second on some of our outcomes using bimodal neuromodulation. Obviously, hearing loss and tinnitus prevention is a really important thing. So maybe not just trying to manage what's there, but keep it from getting worse or keep it from happening at the same time. Thank you for helping us to understand why are our music venues as loud as they are. There's culture behind that. What we really are looking to do is we're looking to break some of this cycle. We've got 3 different locations in the brain that are amenable to intervention. Which are the ones? Well, if we cause a person to no longer hear their tinnitus through some sound therapies because we have effective masking going on, well, then their amygdala is not going to be as activated. They're not going to have that panic reaction. If their amygdala is not having a panic reaction, it's not going to communicate over to the thalamus, this thing's a threat, so pay attention. We've got all of these different areas that we can target. So tinnitus, it's not that there's nothing we can do about it. There's a lot we can do for it. A point that I want to make around tinnitus masking is, and this is especially true with musicians, we do not mask tinnitus energetically, as in the tinnitus sensation is not being caused by some external signal, and an external signal can be masked by providing other sound that has energy in the same critical band, like that 1/3 octave band around that center that is that external sensation or that external sound. We can use energy in that same critical band that would actually mask your ability to detect that tone. Tinnitus is an internal, it is a circuit noise, and where on that ascending auditory neural pathway it exists is not known, nor will we ever know. It may only be in the brain. So try to activate those neurons around that. Hard to do, if not impossible to do. And so we actually mask it via kind of central masking or what's called informational masking. So it's not about presenting just some broadband noise. It's about providing a sound that is vaguely pleasant but easy to ignore. Rain, ocean waves, the sound of wind, the sound of birds, crickets, whatever is vaguely pleasant, easy to ignore. And that's individual for each person. So if people hate crickets, you're not going to recommend that they're going to use crickets to help mask their tinnitus because the masker is more annoying than the tinnitus is. But if they like the sound of rain or they like the sound of monks chanting, do that. My favorite app is the Resound Tinnitus Relief app. Not saying I'm a fan of Resound or not, but their app is really good. This is what I like. Rain Ocean Monks. That's what I go to sleep with every single night. I just have that playing. Now I have about 20 different soundscapes. You can program in different soundscapes. All right, I told you guys I would give you just a little bit of data on outcomes from my own clinic. So this is real world evidence. We presented this, my colleague, Miles Sabine, he and I presented this at the Tinnitus Research Initiative last June in Vancouver, Canada. This thing called bimodal neuromodulation, it's been used in management of addiction, pain, and anxiety. It's been effective with that. It's a non-drug approach to changing your experience with an otherwise noxious sensation. So what's happening is you're delivering 2 different modes of sensation. So not just unimodal stimulation, but bimodal stimulation. And in tinnitus therapies, what you're doing is you're presenting a sound while at the same time presenting something that is a somatosensory, so a sense of touch. You're presenting them in concert with one another. And the way that it's delivered is it's being done synchronously. By the fact it's being done synchronously, it is causing a remapping of the neural networks that are projecting from the limbic system into the thalamus, and very specifically causes the attention center of the brain, the thalamus, to lose its priority that it had given to the tinnitus. This was published, there's 3 clinical trials that were conducted. Most recently, it came out in 2024, showing that was safe and efficacious. And so that's why I got FDA approval March of 2023. All right, drum roll. So Miles and I presented this at the TRI initiative. So we've got a little over 300 people that we fitted this to. The data are about the same, but this was the initial data that I've previously presented. Change in tinnitus handicap inventory is along the ordinate, the y-axis, on the left-hand screen, with a dotted line at a reduction of 7 points on their pre-treatment THI compared to their post-treatment THI. And so 7 is that minimally clinically important difference. So our average improvement at follow-up number 1, which was 6 weeks after the initiation of therapy, their average improvement was a 16-point reduction. And then there was further improvement at week 12. So it's a 12-week program where people sit every day and they do 2 sessions that are half-hour each. So the idea is that you do 90 hours spread out over 90 days of this particular therapy, and it causes, in the correct individual, somebody who is a good candidate for this, it causes them to lose the ability to maintain focus to their tinnitus. And as such, we break that cycle. So the percent of people who were responders, that's on that right-hand side. So from baseline to follow-up number 1, so 6 weeks, we had roughly 65% of people achieved at least a 7-point improvement. And then at 12 weeks, we had a few more people then who reached that minimally clinically important difference. However, how many people who had mild tinnitus, we actually had people with mild tinnitus still achieve some improvement. Those with more severe degrees of tinnitus had a better outcome. Just to point out, our severe and catastrophic range, so people who had the worst tinnitus had the best outcomes. So on that note, I just want to say thank you very much. I appreciate everybody tolerating this noxious sound coming out of my mouth. Thanks, Frank.
Talking Ears is a production of Earmark Hearing Conservation. The theme music is by Scott Hallam. You can find more of his music at audiodowsing.com. The show is produced and edited by Juan Vasquez, Scott Hallam, Mary Kim, and myself. Thanks for listening.